very helpful introduction. My work here is largely supported by a K23 from NIDA. And Dave, we can go to the next slide. I've mapped out conceptually the 11 different criteria for a DSM-5 diagnosis of a substance use disorder. They use the same criteria for all substance use disorders, but of course, in this case, we're largely thinking about opioid use disorder. And if we go to the next slide, I'm just emphasizing that if we look at these two symptoms of physical dependence, which is clearly not synonymous with opioid use disorder, we can see how the nomenclature in DSM-5 has been very helpful compared to prior versions, DSM-4 and so forth, where we actually, the terminology in the past would have been opioid dependence or opioid abuse. And now the diagnosis is opioid use disorder, specifying whether it's mild, satisfying 2 or 3 of these criteria, moderate, 4 or 5 of the criteria, or severe, which would indicate 6 or more of these criteria are satisfied. And I don't want to belabor this too much. I know a lot of the attendees and speakers are from NIDA and NIAAA, but given that this is trans NIH, I think it's helpful to emphasize, Dave, in the next slide, that in contradistinction to physical dependence alone, addiction at its core really is the loss of control and worsening consequences from substance use. And that may involve, or often may involve, tolerance and withdrawal. But the DSM-5 is very clear that the presence of tolerance and withdrawal on their own, even satisfying those 2 diagnostic criteria, are insufficient to warrant a diagnosis of a substance use disorder on their own, because tolerance and withdrawal, physical dependence, are predictable physiologic responses to certain classes of substances. Clearly, opioids, within a matter of even 4 days or so, humans will develop tolerance. Benzodiazepines, my understanding is after about 4 months of daily use, about 50% of people would be physically dependent on benzodiazepines. We have a serotonin discontinuation syndrome if we think about certain SSRIs and SNRIs when they're stopped, especially abruptly. People run into a lot of physical, or could run into physical or psychological discomfort as a reaction to a quick taper. What's more interesting, especially for today and tomorrow, thinking about all of these issues together, is that in our textbooks, in our clinical exams, often the case scenarios represent a patient with one or the other, or one specific diagnosis. But in reality, these populations overlap tremendously, and that's not only at one point in time. But I think also what tends to be overlooked is that these complex patient populations are very dynamic, and the individual's trajectory over the lifespan really could go back and forth between different kinds of conditions that overlap in different ways and interact in different ways over time. If we go to the next slide, this is a figure that I developed for the HEAL Initiative a few years ago. And if we start in the blue square, just thinking about populations with opioid use disorder, a prior overdose, opioid misuse, non-medical use of opioids, whether or not they have pain. And we think about different risk factors that either lead toward fatal overdose or are protective against fatal overdose. Those are listed here. At the top, I've emphasized ongoing non-medical opioid use. Clearly, adverse events related to opioid use are more likely to occur among individuals who continue opioid use, especially not under the supervision of a clinician. But in addition to overdose, at the bottom left in the circle, there are many other outcomes, many other adverse events, comorbidities, and consequences that we worry about for individuals and the people near them that can be impacted by risky opioid use. At the bottom, I'll just emphasize, because this, and I think there's really a growing empiric basis indicating that the initiation of medication and the successful retention of patients on medication for those who have opioid use disorder are, if anything, the 2 milestones that are most important for reducing the risk of overdose and fatal overdose. And this is difficult enough for populations with opioid use disorder, but when we think about populations with severe opioid use disorder who also have a or multiple pain syndromes, then this gets even more challenging. So if you go to the next slide, If we think about overarching frameworks that can be helpful, the Cascade of Care framework is a framework that has emerged throughout medicine, in particular in HIV, but thinking about managing chronic disease. The Cascade of Care frameworks, which employ sequential stages through which patients or individuals must successfully pass to get to the next stage, is very appealing because it can help in multiple ways. It can help, it's both informed by practice guidelines, but can also further inform practice guidelines, especially if we think about accreditation standards and the way that programs are incentivized or required to operate. It can inform quality measure development, funding allocations, and value-based reimbursement. It can also, I just want to emphasize, the Cascade of Care framework can be useful for both monitoring individual progression or treatment history, but also thinking about populations, across settings and time, and it can inform further research. So if we go to the next slide, this is a figure from Gardner's work around this is an adapted figure of Gardner's work from 2010 that Nora Volkow, Eugenia Socius, and Evan Wood published in 2016 in addiction, showing how if we were to attempt, at the top you can see this cascade of people living with HIV who are diagnosed, linked to HIV care, retained in care on antiretrovirals, and successfully virologically suppressed. At the time in 2011, these numbers were pretty low. In the intervening time, if you look at this final stage of virological suppression, that's now closer to 50% in the United States. So just in the matter of 8 or 9 years, a lot of progress. And at the bottom in figure B, you can see that the authors are trying to fill in these stages with the best available estimates. If you go to the next slide, Dave, this shows the cascade of care specifically for opioid use disorder, not just substance use disorders in general. And the bright red indicates the gap under a 90-90-90 goal, which is what in the HIV field was established as a goal both to maximize individual health, but also to reduce community transmission, further transmission, because people who are treated and undetectable in terms of their viral load become untransmissible to others. We don't have those biomarkers in opioid use disorder or in pain syndromes for the most part. And it's not infectious. Opioid use disorder or drug use behaviors are not infectious in the same way. But it can also be helpful for us just to model, well, what are, based on our best estimates, our success rates across the nation in this case for diagnosing and engaging in care, initiating medication and keeping people on medication for a minimum of 6 months, if not really 1 or 2 years, and helping them achieve full sustained remission, if not even going further and thinking about a subsequent stage of recovery. And in this case, based on the best available estimates, in particular from SAMHSA, so we think about NISDA, the National Survey on Drug Use and Health, on NSATS data, looking at treatment episodes or the census of people who are in care on a given day across SAMHSA-funded programs. Our best estimates suggest that there are about 2.1 million people with opioid use disorder, and about 20% of them receive care in the prior year for opioid use disorder, but that only about 35% of those care episodes initiate a medication for the treatment of opioid use disorder. These data are extremely limited. There are many caveats baked into them. And as difficult as it is to estimate the prevalence of opioid use disorder in the population in the country, I would suggest it's even harder to disentangle who has opioid use disorder alone, who has both opioid use disorder and pain syndromes, and who has a pain syndrome where the opioid taking behaviors may be non-stable or erratic, but it really reflects the underlying pain syndrome or lack of response to treatment rather than opioid use disorder per se. So our data collection and reporting systems are extremely poor for opioid use disorder. We've been struggling this for many years. It's even hard to know how many people are receiving medications and for how long. So I'll give a few examples coming up. If we go to the next, we could advance 3 or 4 slides actually. Just to reiterate how the Cascade of Care framework can be applied, it's really in many different domains. I think 2 more slides. Great, yep, very good. And there has been in the last, I suppose, 3 or 4 years, there have been more and more papers coming out using the Cascade of Care framework, looking at different populations with different data sources. I've also reviewed many that are in press or on the cusp of being in press. And it can be very useful. There's been a lot of work coming out of Vancouver, also across the US in major cities and states using claims-based data such as Medicaid claims or treatment episode data. So I won't belabor this, but if we keep going to the next slide, the yellow circle is indicating these final stages of the cascade, which really are treatment stages. So if we think about people, especially people who are entering treatment for the purpose of treating opioid use disorder, that is only a portion of all of the services and considerations that we'd want to think about for these populations, especially when we think about the more complex populations with pain. And in this current figure on the left, you'll see we've indicated primary prevention and secondary prevention. On the next slide, the treatment stages that are encircled in yellow are on the right side of this figure, which I know is pretty busy. But the point is, and this is from a textbook, the APA textbook that Michael Compton and Mark Manso edited on opioid addiction and American crisis. And this was the final chapter that I'd authored for them on quality improvement initiatives. And the treatment cascade on the right, with this continuum between treatment and recovery, at the bottom also especially front-loaded harm reduction services being helpful for these patients who may not be oriented towards abstinence, at least initially, or at any point as their main treatment goal. Treatment is really just a part of everything else that could be or needs to be happening in the US. And I've tried to stratify here into darker red sections the higher risk populations. And these would be people who may have been presenting to the emergency room, had overdoses, who've been cycling through treatment, incarcerated at times, and that we might want more intensive monitoring of them. If we think about prevention, many of these patients arguably would meet criteria for opioid use disorder and then should be connected to care and shunted to the right. But for those who may be screened, higher risk or medium risk populations are monitored through these other interventions. It may be that we could prevent what might be a mild opioid use disorder or opioid misuse from progressing to more severe conditions over time. So if we keep going, well, now it was, I suppose, 2 years ago that the APA was awarded a CMS grant to become a measure developer. And we've been working with NCQA, which is a measure, one of the, well, really the predominant measure developer in the United States, to think about how to develop measures that could facilitate care. And the reason this matters for those who aren't familiar is that measures that CMS adopts into the core measure set for Medicaid or Medicare often become modeled by commercial plans as well. So there are a lot of downstream results in terms of commercial insurers changing their reimbursement formulas, how they manage contracts with large treatment providers or individual clinicians. And we would hope over time that this is helping to move clinical practice in evidence-based directions. The next slide, we can go 3 more slides, list out different kinds of measures. So structural measures would refer to, you think structurally, what in terms of system capacity or resources are in place. That these can be especially useful in terms of thinking about accreditation standards or ongoing licensing and QI efforts. Process measures, which often reflect service delivery, which are easiest to track through a chart review. So thinking about, well, what % of people coming into the emergency room receive a drug test, or what % of people who have a new opioid use disorder diagnosis receive medication for opioid use disorder within the next 14 days, for instance. And then outcome measures, which often are the hardest to ascertain and also difficult to adjust. Although there are growing voices, I think, that process measures as well might be risk adjusted depending on the setting and the environment. But if we think about outcomes, not just among patients with opioid use disorder, but patients with comorbid pain syndromes, this will be different because often we may have patients who are on medically supervised full agonist opioids in addition to being on buprenorphine, for instance. For whether it's through breakthrough pain or for standing medications. So what could be more simplistic measures or monitoring efforts around guarding against co-prescribing, for instance, of MOUD with opioids or MOUD with benzos, it becomes much more complex. So if we go down a few more slides, what I would suggest is 2 or 3 slides here to the one with red lettering. Yeah, a few more. I've oriented the stages in a waterfall, perfect, one before with the red letters. So here the stages are in a cascading waterfall just to accommodate text. And these are examples that are on the current slide showing, for instance, a structural measure for engaging patients in care. If we think about where opioid prescribing, where we have high rates of opioid prescribing, not just pain clinics, but other primary care clinics, neurological settings, do we have among these opioid prescribers, do we have addiction specialists? Do we have peer navigators present? If a patient were to, and the clinician were to suggest buprenorphine, do they actually have waivered prescribers in the co-located or who could remotely collaborate with the care, with the pain specialist? If we think about initiating MOUD, what are these different rates, and over time, how do they change? Are there actual improvements in pain levels? Thinking about retention, what would the role for care coordinators and wraparound services be? And would these be settings where we have these 3 different populations of people with OUD primarily, people with comorbid OUD and pain, or is it really a pain setting where people were worried about them developing opioid use disorder? And then in terms of remission, recovery and remission, I think even more so than in the opioid use disorder patient population, we're likely very much interested in measurement-based care, where we can hopefully track and demonstrate improvement in clinical outcomes around quality of life and level of functioning. And this certainly becomes increasingly complex as we think about comorbidity. So I'll wrap up there and take any questions if people have, especially for clarifying anything that I presented.
Thanks, that was terrific. If you have a clarifying question, please just raise your hand or unmute yourself and speak up. Okay, I'm not seeing any hands. Or
I just wanted to say thank you so much for a great foundational talk and doing that all in 15 minutes. So really modeling how we're getting through this, that was really helpful.
Okay, thank you very much. Okay, next up we have Dr. Ferraro.
Hold on. All right, can people hear me now? I apologize for that.
Yes.
Good morning. So what I've been tasked with this morning is to talk a bit about the biopsychosocial model. As I said in my introduction, I'm a neurologist and my interest has been in pain. And from my perspective, pain is clearly a neurologic disease. And I think it really deserves to be considered from that perspective. However, in terms of thinking about how we treat patients, clearly a consideration of the full extent of the functions of the brain, which include our interactions with ourselves, with our emotions, with the environment, with our friends and family, is a key piece to what we want to talk about. As Dr. Williams said, it's a very complicated issue, and obviously the issue of treating patients who have both opioid use disorder and pain is complicated by the fact that pain is a unique personal experience, that it is a subjective experience. We have no gold standard model of measuring that. And at the end of the day, we need to take what our patients say and try and understand what it means. So with that basis, let me move on to the next slide, which is really, I'm a neurologist. It's hard for me to give talks without showing slides like this. But the reason for showing it is that for many years now, we've been exploring the neurologic system, and we've come to understand that there are lots of receptors in the skin. They communicate with the through the spinal ganglion to the spinal cord, and then in the next slide is transmitted to the brain. Next slide, please. Through the ascending spinothalamic tract, amongst others. And we've come to understand a lot about the brain and this nervous system and how it works. And as shown in the next slide, probably one of the most important components, next slide, please. One of the most important components is that we came to understand that it's not a one-way system, that the brain, in fact, has dramatic effects on through descending systems on being able to control the input that it accepts and how it then deals with that input. And this really didn't come about till the 1960s and began to help us to understand the fact that human beings are able to control what happens in their bodies, and that there are situations in which the brain cannot perceive pain because it's busy doing something else, like running from a fire or saving a friend who's been shot in war. And there just isn't time to think about the pain. And we now understand that there's a physiologic way in which this can happen. Next slide. We've also been very clear as we've gone over time about the genetics, epigenetics, and phenotypes involved in the various syndromes that we look at. This is broadly across medicine. But I think the key feature here is that, we were thinking that maybe it's all genotype. If you're, have two blue-eyed patients, you're going to have blue eyes. What we've come to understand, as emphasized in the orange box there, is that there's an epigenetic type, and that we are influenced by what happens to us and the environment to which we're exposed. We now know that if patients are exposed to pain early on in their lives, they have a higher risk of experiencing chronic pain later on, independent of the genotype. Going to the next slide. We also have learned a great deal. Next slide, please. Great. We also have learned a great deal about the functioning of the brain through a host of different mechanisms, and they're just illustrated here. And what this has done, next slide, please, is to help us to understand that there is a way in which the brain perceives and deals with pain. One of the things that has happened is that we've taken pain from a question-based analysis, which is here on the screen, one of the most commonly used ways of measuring pain, and come to understand that the brain actually has responses. And what this has affected in terms of the way we perceive pain is we've come to understand that pain is a real thing. That's a little bit hard to understand from the perspective of the folks that are attending this session, because we do believe that pain is real. We've all experienced it ourselves. Our loved ones have experienced it. And yet, as a society, we haven't necessarily understood how to deal with it. And it's very hard to know if somebody's sitting there not looking uncomfortable and says that they have pain, how to understand what's going on with them. So the advent of the imaging systems has shown us that the brain is actually perceiving input from the periphery and is turning on systems there that affect it. In terms of our understanding of pain, we've also come to know that it's not simply a single measure, that in pain, even in pain intensity, how is your pain? There are things such as the worst pain, the least pain, and average pain over a period of time. Here asked about a week, but it can be asked over any period of time. Next slide. But we've come to understand that pain has obviously dramatic effects on the rest of our lives, and so measures of those include things like the pain interference scale, about general activity, mood, walking, work, relationships, sleep, and enjoyment of life. And in many ways, this reflects what is part of the biopsychosocial model. Next slide, please. We also have come to understand that the ways in which the brain interacts needs to be considered in a complex mechanism. And what's interesting is that despite all of our knowledge of the underlying processes in the brain, what we end up needing is a model of pain that reflects what we can measure in our patients in a standard situation. And what you can see here is that there's a physical state that usually leads to pain, leading to nociception under that, and then to this box that sits on top of our heads where we perceive the pain, and that perception is dictated in part by our memories and our expectations of the pain, our affect or mood during the perception of the pain, and how we evaluate the pain. An obvious example of the evaluation is that if a patient comes in with a little bit of back pain and they've been working in the yard and they don't have any neurologic findings, we will say, you know, you should rest a little bit, but really what you need is some exercise and physical therapy and better back hygiene. If that patient, however, has a history of breast cancer, what they are really interested in is knowing whether their breast cancer is back as a cause for that pain. So the way they evaluate that pain is going to be different. And in many cases, the solution to the patient with breast cancer and back pain is the knowledge that it is not their cancer, but simply the run-of-the-mill back pain. Therefore, how we perceive the pain leads to actions and to responses, and that feeds back on our environment, and then that feeds on our physical state. Now, this is the model that we use when we take care of patients. Next one, please. In terms of the definition of pain, this has probably been best done through the IASP, International Association for the Study of Pain. And what you'll notice here, as you all know, is that it's an unpleasant sensory and, not or, and emotional experience of actual or potential tissue damage. And one of the problems that comes up with that is that pain always involves some sort of emotional response, and how do we deal with that? Next slide, please. So what's come up over the course of time is an understanding that there are many processes in the brain, that there is sensory discrimination, there is affective disorder, there's cognition, and it is simply a slight expansion on the box map that I showed you before to try and understand the pieces that go into that. Next slide, please. What's interesting is that as we've expanded our knowledge of how to use the tools that we have available, we've come to understand that there are multiple parts of the brain that deal with all of the boxes and the circles that we saw on the previous slide. We've come to understand that if we can manipulate how people feel about their pain, if we can manipulate how they think about their pain and their expectation, we can change the processing that goes on in the brain and their perception of that pain, and thereby the reporting of the amount of that pain or how much it bothers them. And we need to keep that in mind as we move through thinking about how we treat pain. Next slide. So if we look at the history of pain, what we know is that it's a subjective phenomenon. Society has a view of the pain. All of us have heard, no pain, no gain, right? Grin and bear it. My honest you know, cut it out and the painful process will stop. All of which we know is not necessarily the best way to approach these things. Pain without a lesion, without an obvious source, was for many years considered to be not real, or at least not understandable. Things like phantom limb pain, healed surgical wound pain. And what's interesting is that we've always had an example where we could actually see something change, now called chronic regional pain syndrome. But this occurs in about 1 in 1,000 surgeries, especially bunionectomies, and why that should occur, we just didn't understand. And what functional imaging has really done is to end the debate about pain as being real. But it still is not able to provide us with a severity measure, because the amount of brain that is turned on or turned off is not, although somewhat correlated with the amount of symptoms that patients are experiencing, is not correlated with how much it bothers or affects the person. So, next slide, please. That brings us to the biopsychosocial model. And it's interesting, I was asked to talk about the biopsychosocial model, and it's taken me several slides to get there, primarily because what I wanted to do was to lay out that we now understand that what George Engel and Juan Romero came up with in 1977 about thinking about the totality of patients' experience was really prescient in terms of thinking about how our bodies work. We need to think about the psychological versus the physiologic in seeing the possible sources of pain and understanding that just because we see it on an X-ray doesn't mean that it hurts. And this is emphasized many, many times in back scans and in knee scans. The amount it hurts is not shown there. Different people clearly respond differently to the same stimuli. Why should that be? And pain perception is really all in the head. When patients ask me, is this in my head? The answer to the question is always yes, because no brain, no pain. We really need the brain in order to perceive the pain and report the pain. But what they really mean is, are they making it up? And the answer to that is clearly no. But it's not only about what the patient thinks, because we need to understand what goes on, and especially in considering treating a patient who's got both opioid use disorder and pain, it is not simply the messages that the patient is giving us that will help us, but some other things that we hopefully will talk about over the next day and a half. And so we need to think about what caregivers need to know in terms of explaining how the pain helps. And we need to understand that detailed explanations about pain may not always be helpful, but sometimes can hurt. And we've seen this in patients who come in with incredibly detailed descriptions of what happened to them and why that has caused their pain and what it means in a way that goes beyond things that are useful to us. And we need to help patients learn to live with their pain, but not to be controlled by the pain in seeking a cure. Even if we knew that every connection in the brain, and one of the issues that comes up with regards to that is that as much as we've learned about pain, even if we knew every connection in the brain, we still would not be able to explain how this functions, interact, and work. If you think about the computer that you're currently looking at, there's somebody somewhere who understands every connection in that computer, but they don't know whether you're on a Zoom call or a Blue Jeans call or maybe doing Word or watching YouTube without some sort of a screen that reflects what's happening. Because we can't analyze every electron in that device and understand what's going on, we need some sort of measure. Next slide. And next slide, please. I'm sorry. And so the advantages of the biopsychosocial model is that what it does is provides us or helps us with that screen to understand what's going on. It helps us to figure out what's most important to the patient. It promotes the multimodal approach to the treatment of pain. It encourages multidisciplinary pain care to adapt to specific populations. It emphasizes the roles of psychosocial, socioeconomic, ethnic, ethnicity, and gender factors as important components to the underlying perception and expression and impact of that pain. We need to consider cultural competence and cross-cultural factors and how patients manage stress and can be helped to gain control of their lives. We need to understand the illness experience that the patient is going through and communicate health information to the patients and their families, which facilitate motivation, behavior change, and movement towards improvement in their pain. It really is taking a modern approach to the culture of health care as opposed to medical care. Next slide. The biopsychosocial approach, we need to learn to live with the pain. We need to validate our patients' struggle with compassion, need to understand and be involved in their treatment, but the patients need to be involved in that treatment as well. Pain care is always a collaboration between the healthcare person and the patients, and we need to provide patients with a sense of self-control over their pain and how they treat it. We need to help patients set realistic expectations and try to avoid the negative behaviors that can come about and catastrophizing that can go on, and provide them with coping skills that helps them to take control of their pain and rebuild their self-efficacy and understand how to deal with that pain. It really is treating the whole patient and not just treating the symptoms or the pathology. And the biopsychosocial model has been around for many, many years, and really has been confirmed by now our understanding of the brain and the nervous system and how it works. And I think provides us with that screen that we need, that entryway into the patient's performance and their thinking and what's going on that will help us to understand how best to treat them. Now, let me leave you with one last thought. Next slide, which is that the brain is a remarkable tool. And I show this because what I'd like you to do is to look and see whether you see a chalice or whether you see faces. And hopefully you can see one or the other or both, depending on how you look at it. Try and see both at the same time. That's very hard. We can switch between one and the other, but we can't see both. The second thing is we're taking a single input of a picture into our brain and interpreting it in two different ways. And from my perspective, if we could get to the point where we could turn pain on and off with the ease with which we can see both of these pictures, we'd really make a remarkable change in how we deal with things. And training patients in how to use their brains to control pain and to control the other symptoms that they experience is a key part of what we need to do. I'll stop there. Thank you.
Thanks very much. Any clarifying questions?
Bob, I'm wondering if you wanted, is this a clarifying question or something for discussion?
It's a
Do you want to say a little bit more? Okay, great, thanks.
Okay, move on to Dr. Kertész.
Okay. Let's see, the slides will come up in a moment, I think.
Yes, give me 1 second.
Sure. Let me, as he's bringing those up, let me mention that I really appreciate the chance to speak to people today. The title, which we'll see in a moment, Opioid De-Prescribing as a De-Implementation Science Challenge, aims to convey a reality. There is a back and forth between two levels of operation. What clinicians and scientists assess would be good care for patients with pain who are on opioids or maybe not on them, and what institutions do to alter care for those patients. And I'll treat both. There are unanswered questions about what to do for each patient. But that second level, what institutions do, deserves its own rigorous scholarship. Please advance slides. Disclosures are shown. I don't represent my government employers. I don't have pharmaceutical grants for money. I do privately own shares of these companies, Thermo, CVS, and Zimmer. I've been focused on vulnerable populations with research funded by VA and NIH since 2002. Next slide. I'll start by showing a cartoon which the editor of Substance Abuse Journal, Adam Gordon, urged me to put together for an article. It features a patient and a physician in an office. They're surrounded by mention of an overdose epidemic, the CDC, the DEA, prescription drug monitoring, and the doctor says, too many people are dying. The situation's out of control. I kind of thought they were helping you, but right now I have to stop your Lortab pills. And the patient says, what did I do? And right outside the window, as you can see, there's someone injecting in a graveyard full of syringes. And I think we all know that there is a relationship between what happened in offices over the last 2 decades and what happened out there, so to speak. At the same time, however, this is a very fraught moment for 2 people, and it involves a public health concern. Next slide. So let me state my theses. There are about 10 million patients on long-term opioids for pain if you calculate from a paper by Mojtbai. Stopping or tapering those opioids for those patients is a clinical intervention for a person. Clinically, we need to move toward rigorous assessment of what accounts for both good and outcomes when we do that. Now, when healthcare systems act to cause stoppage or tapering of opioids, that's a form of de-implementation for the system. De-implementation can be done well or it can be done poorly. And we have a framework for studying implementation and de-implementation called the Consolidated Framework for Implementation Research, which can really help us. Next slide. The context here is one we all know. Prescriptions for opioids, opioid use disorder, and deaths from opioids rose in parallel through 2012. According to the NIH, prescription opioid use disorder and heroin opioid use disorder more than doubled, and that's national survey data. Among whites who responded to that survey with heroin opioid use disorder, 53% said they started with pills. Obviously, prescription declines began in 2012, but overdoses persisted for reasons that are complex, but we know that. When Dr. Gordon and I wrote this paper for addiction, we were concerned about an imbalance between very strong prescription control policy responses and relatively weak responses in both pain and addiction care. Now, systematic opioid prescription reduction is de-implementation, and I'm going to go into that. Next slide. So we have to define what is de-implementation. When Norton writes that it's reducing or stopping services or practices that are ineffective, unproven, harmful, overused, or inappropriate. Vinay Prasad categorizes practices eligible for de-implementation based on those that are contradicted by evidence, those that are unproven, even when there is evidence, and novel interventions that simply don't have data. But as we'll see, de-implementation as a concept fits easier on some treatments than others. Next slide. So if you look on the left, antibiotics for routine upper respiratory tract infection, here we're talking about a discrete diagnosis. It involves a virus and a runny nose, maybe a sore throat and a cough. The stakes are low. Every doctor is trained to recognize and treat this. Antibiotics are ineffective, we know this. And de-implementation, and this is actually hard to do, is to not start antibiotics, but to offer some alternative ideas at the time the patient presents with a viral URI. The fit is a little trickier when we talk about opioids for severe chronic pain, because chronic pain, severe in nature, is an experience. It has peripheral and central drivers, as you just saw in the last talk. It ideally, our care for chronic pain sits in a rehabilitation framework of multi-morbidity. The stakes are incredibly high, and sadly, doctors are mostly not trained in evaluating or considering this condition. And would that it were the case that opioids were completely ineffective, but they have a modest effect on statistical average, which means that some people are going to use those, some people are going to use other things unless we make opioids fully illegal, which we're not going to do. And then you get to this question of what is de-implementation? Is it not starting them? Is it tapering them? Is it stopping them? So there's a murkiness there when we apply this concept. Next slide. Nonetheless, de-implementation applies anyway, and I'm giving you 2 exhibits here. The first is on the left. It's a statement from a respected health agency, the CDC, published in NBC News in 2017. Opioid prescriptions are down, but not enough. MME total for the country were 3 times higher in 2015 than in 1999. When a major agency declares a failure to attain goals, that is creating impetus for change. That is an act of de-implementation. Over on the right, you see the National Committee for Quality Assurance quality metric, the proportion of patients who receive opioids at over 90 morphine milligram equivalents. It is an indicator of poor performance. It's used to alter payment to providers. When a respected agency establishes a metric that affects reimbursement and quality ratings to reduce prescribing, that is an act of de-implementation. Now, these 2 particular exhibits have something in common, which is that they do focus on total MME for the country and per day for a patient. but there's just 5% of patients receive 59% of all MME in the country, according to analyses by Sun and Jenna. So these two interventions, both are targeting the same group, those folks already on opioids long-term, notably at high dose. Next slide. De-implementation is happening. The figure on the left shows declines as reported by IQVIA, particularly for those high-dose prescriptions in green. Prescriptions per capita in 2018 were 19% lower than in 2006, which is the earliest year on the CDC website. Decreases are more concentrated now for persons who have higher dose histories or who have worse pain, according to a paper published in 2020. Our focus is on those 10 million or so currently on long-term opioids. And all emphasis from payers is on reduction for those people and on preventing more of those people from coming into existence. Next slide. If that is your focus, then TAPER becomes part of the conversation, and TAPER has some clinical promise. There are major clinical trials ongoing. In fact, some of the speakers here today are conducting them. There was a review published in 2017 in which they looked at 40 studies with patient outcomes, of which 5 were randomized controlled trials, with a total of 261 patients. Most were short-term trials. They involve voluntary patients. None rated as good quality, but there were improvements in pain and pain-related function. However, the authors were quick to stipulate that there was no data on mandates, and there were few data on harms, such as suicide or transition to illicit drug use after stoppage. Next slide. If TAPER has clinical promise, it also has some clinical troubles. The year 2019 saw serious declarations from 3 federal agencies, starting with the Food and Drug Administration announcing that rapid taper or stoppage could cause death of the patient through suicide. Then the CDC announced that its guideline had been widely misapplied to imply that all patients above a given dose should be reduced automatically. And then the US Department of Health and Human Services issued a very helpful guidance on this exact issue. The same year saw the emergence of 6 observational papers with various outcomes such as overdose, suicide, illicit drug use, or hospitalization outcomes after stoppage of opioids, including one I helped spur and co-authored from the VA that showed 5 times elevated rate of suicide death among veterans who were stopped after receiving for over 90 days. None of these papers prove cause and effect. But I caution that we pivoted policy toward pushing dose reduction on patients already on opioids based on retrospective observational studies. The situation with 2 sets of studies like this suggests that we may have missed an element in how we construe and understand the problem of what our prescriptions do and what they don't do. Perhaps more direct and more obvious is that 81% of doctors admit that they are simply reluctant to care for patients on long-term opioids. And in one study from Michigan, 41% refused to provide care at all for such patients. And obviously, it's very difficult to deliver safety for patients if you're unwilling to deliver care for them. Next slide. The questions I think that we should move toward start with, does opioid taper confer safety? It's being mandated. I see letters from insurers saying this needs to happen. It's still part of our quality metric enterprise. So does it confer safety or not? But since I think we're going to get a mixed answer on that, perhaps better we should ask the following. What distinguishes situations that obtain good outcomes from situations that obtain bad ones? Are they patient factors? Are they medical diagnosis factors? Is it elements of the social context? Is it the speed of the taper? Is it the consent of the patient? There are many situations in life where the difference between a good experience and a bad one is whether there was consent. And finally, core to me is why the suicides. There are now several hundred of these that have been reported by grieving families online. They're being cataloged by private individuals, but not by government agencies. My team and I feel that these actually need to be studied in depth so we understand what are the contextual and clinical factors that feed into them. We are preparing a study right now, which is going through IRB review. I've shown you on the right an example of a tweak designed to recruit family members. It's called CSI Opioids. We want to engage in psychological autopsy. We think this work is very important and needs to happen if we are to ever understand why some people, but not a lot, but some are having a tragic outcome. Next slide. The Consolidated Framework for Implementation Research can help us think about how to do this work. It has several components. I can't explain them in detail, but they can structure our inquiry. Characteristics of the individuals in an implementation framework refers to the competence and the interest and the motivation of the people who are carrying out the change, such as prescribers, but also allied health professionals. The intervention. So for which patients is change promoted? What service is offered? Is it going to include this service or that service? Is individualization of the care allowed, or is it not? A third component of that model is the inner setting. So when we talk about changing care in an organization, a lot depends on how the inner setting of that organization is set up. What's the learning climate? Is there psychological safety? If clinicians believe that something is not going right, how comfortable do they feel reporting it? The process. What are the actions taken by the organization? Is it metrics? Is it bonuses? Is it letters of warning? I've seen all of these. The outer setting. It's crucial in this domain with a national crisis in which, thousands, tens of thousands of individuals are dying. The outer setting is very important. External policies and metrics, payment and regulatory policies, public declarations from respected authorities. All of these influence what takes place in the inner setting. In all of this, the studies that we often see published rapidly are pill dynamic studies, which show us how many pills went up or how many went down and who they went up for. And I think they really fall short in covering the change that we are seeing in healthcare at this point in time. We can't just study pill dynamics. Next slide. In a paper that is currently under revision, I wrote with Megan McCullough, Beth Darnell, and Allison Varley. We proposed some better metrics. We have many in the paper, but these are just a few that could be used to study the implementation at the systems level. Mortality after opioid dose change, hospitalization after opioid dose change. These are relatively easy to capture. They're not normally reported to the public, and as far as I can tell, many systems are not seeking to measure them at all. Particularly underestimated or neglected metric we draw attention to is at the lower left, the number of patients who leave a provider or who leave a health system after a pain care policy change. This is often treated as a kind of neutral loss from the denominator that's not informative, but I think actually we're learning that patients are leaving systems very intentionally, and that actually may be a sign that something has gone wrong. On the right, we offer some patient-level metrics. One might include appropriateness of dose based on functional outcomes documented for that patient, which really maps to what the CDC guidelines suggests be the guide for care. And also the patient perception that care processes are consensual. I understand full well as a doctor who prescribes, some of the changes I make are not consensual. At the same time, I think we need to know what the patient perceives is happening to them. Next slide. Okay, in summary. Opioid taper and stoppage represents a de-implementational research opportunity and, in my view, an imperative. Clinically, let's ask what differentiates helpful from harmful forms of taper and stoppage. At the health systems level, let's ask how interventions are carried out. Who does what? How are missteps identified? What role are patients allowed to play in their care? The metrics for studying these issues now need to move beyond pill dynamic studies to indicators of system change and effects on patients and families. We have the right questions. We have the models and tools to answer them, and the patients who very much wish to help us do this work. So let's do it. And with that, I'll stop. Thank you.
Thanks so much. That was terrific. Any clarifying questions?
This is John Ferry. Just with regards to all of the studies that you're planning, how do you account for the concern or the issue of what the patient reports as opposed to what the patient does, as opposed to what happens to the patient? Is there sort of a graded way that you're approaching that?
Yeah, well, in the study that we're planning right now, we're developing the recruitment tools essentially to study the suicides. In that instance, the goal is to integrate three forms of information. The reports of proxies, who would be the family members who lost the individual, which is a standard for psychological autopsy research. The review of the medical records from multiple institutions if necessary. We've engaged the types of people who can collect those records. And then finally, in-depth interviews, which are actually much more extensive. So it's kind of a mixture of survey, qualitative interview, and medical records. All of these are about a person who has died. So our hope is actually to compare that to individuals who've had opioid transitions that were favorable and good, and then try to see if we can get a hint. At the very end of the process, one has to engage in some conjecture about what do you deduce from the triangulation of those sources. There's no God's perspective when one looks at these complicated issues.
Okay, thank you. Let's move on to Dr. Earnshaw.
Good morning, everyone, and thank you for having me. I'm going to cover some material related to stigma in the context of both opioid use disorders as well as chronic pain. Next. I'll note quickly that I have no conflicts of interest to disclose, and here's where my funding is coming from. Next. Next. Thanks. So my aims for today are to first review a few key concepts related to stigma. Then I'll highlight findings from research on stigma associated with both opioid use disorders as well as with pain. And then we'll end by talking about how to intervene to address stigma. And I'll just note here briefly that I prioritize breadth when preparing this presentation today. So there's of course more to cover, but I hope that this provides a sort of overview or foundation for folks. Next. Okay, so starting with our overview of stigma, because people use this term stigma in a lot of different ways, I think that it can be helpful to start with a definition and review a few key concepts related to the term. Next. Goffman, who was a sociologist by training, provided us with an early definition of stigma, which is that stigma is social devaluation and discrediting associated with a mark or characteristic. And because he used this mark or characteristic terminology, we often hear people refer to stigmas, by which they mean these devalued characteristics. Next. And unfortunately, we have many examples of marks and characteristics that are socially devalued and discredited within our society. So they include physical illnesses, which may span chronic pain, mental illnesses such as bipolar disorder, what social psychologists like myself sometimes refer to as social norm violations, such as opioid use disorders, and demographic characteristics, such as certain racial and ethnic backgrounds. Now, I will say, following the presentations of Dr. Williams and Dr. Farrar this morning, which highlight the complexities of OUDs and chronic pain, I'll note that these groupings are a bit overly simplified. I can get away with this sometime with this slide with social psychologists, but I feel like I should put that caveat out for this group. But this slide hopefully gives us a sense that we have many different types of stigmas that fall into sort of different categories. Now, some of us may have noticed that when we hear people use the term stigma, they're not always referring to a particular socially devalued group. They're often referring to a broader sort of social phenomenon. And that's because theorists and Goffman have really honed in on this social aspect of stigma. They've highlighted that stigma results from a social process. So Link and Phelan theorized that stigma emerges at the co-occurrence of labeling, stereotyping, separation, status loss, and discrimination that's all occurring within a power context. Now, ultimately, it's this social process that leads to the construction of certain marks, identities, or characteristics as indicators of a tarnished character. And then these marks are used to justify discrimination towards and power loss of people who have those marks. So overall, this just means that when we're talking about stigma, we're often talking less about these individual marks or characteristics and more about this broader social phenomenon that results from this process. In the past decade, I'll just highlight that stigma has been characterized as a fundamental cause of population health inequalities, meaning that it is persistently associated with health inequalities over time, despite changes in risk factors, health interventions, and diseases. And this characterization has started to sort of shift the way that we are thinking about and studying health-related stigma. Next. So in the past, much of the research on and interventions that we have developed to address health-related stigma have occurred within disease silos. So we've had fields of research, for example, focused on a deep dive on HIV stigma, on mental illness stigma, and obesity stigma. And these fields don't always have a ton of overlap, but there has been some pushback on this recently. Next. Theorists have been highlighting that the theories that we use to understand stigma, the research methods that we have to study stigma, and our intervention approaches to change stigma may actually be quite similar across different diseases. So to make meaningful strides in understanding and addressing health-related stigma, there have been calls for researchers to deconstruct these existing silos and to utilize cross-cutting approaches to stigma research and intervention. So this was the focus of an NIH and Fogarty-sponsored special issue on cross-cutting approaches to health-related stigma research that was published in BMC Medicine in 2019. So it has some nice resources in the special issue for folks who are interested in the area. Next. One of the things that a cross-cutting approach to stigma research allows us to do is to think about the processes linking stigma with health outcomes among individuals across a wide range of disease contexts, so including both opioid use disorders and chronic pain. So in that first box there, you'll see that we start with the social process of stigma that we've been talking about. Then our framework suggests that this social process of stigma is manifested or expressed and experienced within our structures and among individuals, which you see in the second box. Next. On the next second, I'm going to take a moment just to define these because they're actually often the focus of our stigma research as well as our interventions. So structural stigma is defined as societal level conditions, cultural norms, and institutional policies that constrain the opportunities, resources, and well-being of the stigmatized. So an example of this related to today, it would be the war on drugs. At the individual level, we often differentiate between perceivers and targets. So perceivers are people who don't necessarily live with a stigmatized characteristic and may perpetrate stigma towards others. So this would include medical doctors, potentially employers, coworkers, friends, family members, community members in general. So perceivers may endorse prejudice, which involves negative emotions and attitudes like disgust or maybe pity. It involves stereotypes, which are group-based beliefs that are often applied to individuals, as well as discrimination, which is poor or mistreatment of individuals, such as an unwillingness to treat certain types of patients or maybe providing worse care to certain types of patients. Now, targets are people who live with the stigmatized characteristic themselves. So targets include people living with pain or living with an opioid use disorder. So they may experience internalized stigma by endorsing negative beliefs and feelings associated with a stigma and applying them to the self. They may experience experienced or enacted stigma, which includes experiences of discrimination in the past or present, like actually receiving poor care in medical setting. And they may also anticipate stigma, which refers to expecting experiences of discrimination in the future, like expecting I may experience worse medical care. A cross-cutting approach suggests that these stigma manifestations themselves may be somewhat universal, but they may be expressed or experienced a little bit differently depending on the stigma. So for example, a stereotype of someone with an opioid use disorder might be that they're likely to steal, whereas a stereotype of someone with a chronic pain might be that they're maybe weak or not telling the truth about their pain. Next. So if we return to our figure, these stigma manifestations are in turn related to a suite of mediating mechanisms, which you see in that third box. So our stigma manifestations undermine access to resources, such as when someone is fired from their job due to an opioid use disorder and then has less access to income. They affect people's health behaviors, such as when someone copes with enacted stigma, maybe by using substances, and they lead to stress. And then ultimately, these stigma manifestations and these mediating mechanisms undermine people's mental and physical health. Next. So I'm now going to briefly touch on research findings on stigma and opioid use disorders and pain. Next. So research on stigma associated with opioid use disorders appears to be increasing right now. At the structural level, the war on drugs is perhaps one of the most commonly cited examples of structural stigma. So these policies are critiqued as treating people with substance use disorders as criminals rather than people with chronic illnesses, and they lead to increased risks of incarceration, which of course can impact people's health outcomes. An additional example might be underinvestment in evidence-based treatments, such as medications for opioid use disorders, which limits people's access to healthcare that might save their lives. At the level of the individual perceiver, people who don't necessarily have an opioid use disorder themselves Some work has focused on healthcare providers and shown that nurses working in treatment settings who are higher in implicit or unconscious prejudice have greater turnover. And we also know that stigma is associated with worse provision of healthcare services. In other areas, perceivers note that they'd be less likely to hire someone with an opioid use disorder. They agree with refusing housing to people with opioid use disorders and say that they wouldn't be friends with or want someone with an opioid use disorder to marry into their family. At the level of the target, the person living with the opioid use disorder themselves, we see evidence that stigma is associated with greater delayed treatment access and higher rates of dropout. So as an example, people who anticipate more stigma or worry more about how others will view them report delaying starting treatment, and people with greater internalized stigma seem to drop out of treatment at higher rates. Also, people who experience more stigma have more substance use symptoms, so continue to engage in opioid use, perhaps to cope with the stress of experiencing stigma from other people. Next. In comparison to opioid use disorder stigma, it looks to me that the pain stigma is actually quite understudied, although there does seem to be growing research in this area with more people conducting studies here. There has been a review of the pain stigma literature, and that review suggested that pain that is chronic, severe, and not clearly medically understood is more stigmatized. At the structural level, researchers have identified the inadequate availability of treatment options as an example of structural stigma, which leads to the persistence of pain. They've also identified an insufficient coverage of pain in medical curricula as an example of structural stigma, which means that doctors and nurses may not be adequately prepared to treat or to work with patients experiencing chronic pain. At the individual level among perceivers, research suggests that healthcare providers discount pain reports and doubt the credibility of people with chronic pain that isn't medically understood. Among community members more generally, evidence suggests that people report disliking people with chronic pain and having low levels of sympathy towards them. Among targets or people who are living with chronic pain themselves, evidence suggests that experiences of stigma can lead them to question the credibility of their own experiences, which then has downstream impacts on mental health. And experiences of stigma can lead to worse rehabilitation outcomes, so less successful rehabilitation and also leaving earlier than recommended. Next. So last but certainly not least, I'll chat for one moment about how to change stigma. Next. So right now, we don't have a single silver bullet to cure stigma, just like we don't really have a single silver bullet to cure substance use disorders or chronic pain. But we do have many tools in our stigma intervention toolkit. So in other words, we've developed a sense of strategies that work to decrease stigma, and often these have been taken from those other, silos from the beginning of the talk. So at the structural level, there is evidence that legal and policy changes can reduce experiences of stigma among targets and improve health outcomes. There's evidence that communicating diversity values within organizations can lead to lower anticipated stigma, and principles of behavioral design can constrain people's opportunities to discriminate in the first place. Among perceivers, intergroup contact or interaction with people from groups that are different from oneself is one of our most powerful tools that we have to reduce prejudice. It seems to work best when people interact directly with others, but good news for COVID times, it can also happen through the media, like reading a book or listening to a story about someone who's different from the self. Education can help to address stereotypes and cognitive dissonance interventions that help draw attention to conflicting values, like taking the Hippocratic Oath to care adequately for all patients, but then providing discriminatory care to some patients can help as well. Among targets, counseling approaches that are tailored to unique stigma experiences appear to be helpful. Adaptive coping interventions can be promoted in individual and group settings, and some emerging evidence suggests that even brief writing interventions can address stigma and improve mental health. Next. We also have a sense of how to implement these strategies or use these tools in ways that make them a bit more effective. So multi-level approaches that combine tools at those different levels intersectional approaches that address stigma associated with multiple characteristics at the same time, like opioid use disorder and chronic pain, and longitudinal approaches that deliver intervention components or content over time appear to be more effective. So we still have a good amount of work to do to address stigma, especially stigma associated with opioid use disorders and chronic pain. But we do have a sense of some of the tools that might be helpful, and we have ideas about how to use those tools in order to make progress. Next. So thank you very much for your attention.
Thanks, Valerie. Any clarifying questions? Okay, I'm going to turn it over to Chris Beasley.
Thank you, Leslie. And thanks for organizing this topic. You know, it was one that was discussed at the HEAL multidisciplinary work group as a gap in the current NIH portfolio. So it's really nice to see this moving forward. I don't see my slides.
1 second, they're opening.
Okay. Can go to the next slide, please. So as I just mentioned, this is obviously an incredibly important topic, and in the past we've tended to talk about these things as isolated and separate. And what I would propose to you today is that we're really dealing with an epidemic in our country of chronic illness. And this becomes important when we talk about these in the context because of how we need to change our models of care and treatment options for people with these conditions. Next slide, please. And we've really become a nation of chronic disease. This is a slide from the CDC. So 6 in 10 American adults have one chronic disease, and 40% of us have 2 or more. Next slide. And 90% of our nation's $3.5 trillion in annual healthcare expenditures are for people with multiple chronic conditions. But with few exceptions, our healthcare system really hasn't adapted from a model that's really set up to treat acute problems to team-based care, which is what we know we need for these conditions. Next slide. And right now, you know, especially since the CDC guidelines were published, there's been a shift kind of in the current clinical care for chronic pain to have a hyper focus on 2 numbers. One is a VAS score, how bad someone's pain is, and the second is an MME. So how much opioids are you taking? What's your dose? Next. But I would really challenge us to think about what these numbers really tell us. They're important, and we need measurements and we need numbers, but in most cases, there's a lot more to the story. We need to dig a little deeper in order to really understand. So on the top 2 examples, you can see that, you know, you can have someone who's on the same dose of opioids and could be completely pain-ridden, dysfunctional, and not contributory. Or you could have someone whose pain is relatively well managed and functioning quite well. Same with pain scores. So you can have somebody who's bedridden and in a tremendous amount of pain and not functioning well, and you can have somebody on the complete other end of the spectrum. So again, there's really more to the story. We need to dig a lot deeper in order to understand what's really happening with patients. Next slide, please. But we tend to want to pull apart, you know, chronic pain and isolate it. But it doesn't exist in a vacuum. It exists in a rather complicated, messy environment, which is the person. And that was really nicely highlighted by Dr. Farrar's talk today. Next slide. It is highly, highly complex. So in the upper left-hand corner, not only do we have pain that overlaps or exists with other chronic diseases like heart disease, asthma, diabetes, kidney disease, but on the left-hand corner, it's very common for people with chronic pain to have multiple pain diagnoses or pain in multiple parts of their body. On the lower left-hand corner, it's also common, especially as a person's length of time with chronic pain advances, for them to develop a number of non-pain related comorbidities, such as sleep disorders, mood disorders, cognitive impairment, social dysfunction. And as we've already talked about, depending on a person's biopsychosocial spiritual makeup, the experience of chronic pain is highly, highly individualized. Next slide. So we know we need to change the care model that by and large is not working for the majority of people that have complex chronic pain. Next slide. But the question is where do we start? And I would propose to you that what we really first need to do is take a step back and understand what's important and clinically meaningful to patients. Next slide. This process has really just begun. In July of 2018, the FDA had its first patient-focused drug development meeting for chronic pain. Next slide. Where they brought together lots of patients who had a diversity of chronic pain conditions to really understand what they're experiencing. And in the report that they published in March of 2019 called Voice of the Patient Chronic Pain, the major finding was that the input that they received underscored the diversity of experiences with chronic pain, the complexity of selecting appropriate treatments, and the broader challenges that individuals face in accessing care, treatment, and support. Next slide. There are a couple of key themes that they identified, and the first is that the health effects of chronic pain are pervasive and wide-ranging. So not only do people have widespread body pain, but the resultant fatigue that they experience can be debilitating. Again, they're experiencing sleep disorders, insomnia, and a lot of other things. One of the key findings identified was the fear that patients have about their futures. Next slide. The second key theme was that chronic pain affects all aspects of an individual's life, from their ability to work in or outside the home, to do daily activities and care for their children. Many people discussed the profound impact that it had on their relationships, the deep stigmatization they experienced, the social isolation, and the financial difficulties that result. Next slide. And third is that patients reported difficulty in achieving pain relief, and that effective pain management required a multidisciplinary approach that was tailored to the individual. So participants noted that they really wanted to move towards a holistic approach that included not just biomedical treatments, but lifestyle management, diet and exercise, and psychosocial techniques, with a focus on quality of life. So not just their physical status and functional abilities, but their ability to socially interact, their spiritual status, their economical status, and their psychological well-being. Next slide. And the second initiative that I'd like to share with you today is called the U.S. Pain Collaborative. And it was a project that was undertaken by 6 patient advocacy organizations with support from the pharmaceutical company Grunenthal and consultants Foz Advisors. And really the goal of this project was to identify what questions pain patients want their healthcare providers to ask them about, and whether there's a discrepancy between what providers ask and what patients really want to be asked. So this included a survey of about 1,500 patients that were aged 18 to 80. 2/3 of them had lived with chronic pain for 10 or more years, so they were speaking from a lot of lived experience. There are a variety of conditions that were represented, and 30% of patients are seeing 3 or more different healthcare providers. Next slide. And you're going to see a very common theme as we move through the next 2 slides. So the dark blue bar is the percentage of patients who want their provider to ask about that particular area. And the light blue bar is the percentage of patients who reported that their provider does ask. So you can see it to the far left for pain treatment goals, 74% of patients wanted their provider to ask them about what their treatment goals were, but only 26% of them were asking. For ability to cope, the differentiation was 74% to 27%, and you can see the remainder for their ability to concentrate, level of support from family and friends, and their social functioning. Next slide. The discrepancy here was a little bit less on these questions, but still pretty significant. So in terms of level of energy and fatigue, about 77% of patients wanted their providers to ask about this, and 38% did. Similar with ability to work, level of stress, their ability to perform daily activities, their mood and outlook, and their amount and quality of sleep. Next slide. Some other major findings from that is that less than 30% of patients felt it was important for their pain to be evaluated on a numeric scale. Over 90% indicated that changes are needed to the way providers evaluate their chronic pain. 50% stated that they would like to work with their healthcare provider to decide which questions about pain and which pain measurements are best for them. And we also asked them to evaluate a number of established pain evaluation assessments, and 45% indicated that they were somewhat useful but did not fully capture the chronic pain experience. Next slide, please. So this really suggests that we need a paradigm shift in our models of care for chronic pain, and that if we continue to do things the way that we've done them in the past, we're not going to end up with any new results. Next slide. So I've just highlighted a few areas in terms of our shift in the model of care and understanding of chronic pain that's needed in order to move in that direction. So we need to shift from a sole or major focus on pain severity or frequency in isolation to understanding that chronic pain is a complex multi-system disorder, and we need to focus on function and quality of life. We need to not just understand the disease model, but also the wellness model. So we need to focus on understanding factors related to how one can actually live well with chronic illness, and what are factors that can promote brain health. We need to shift from a sole or major focus on risk factors and factors that can worsen chronic pain to an equal focus on understanding protective and resilience factors and how to promote them. And changing from focusing on how bad things are to understanding what are patients' goals, what's chronic pain stopping them from doing that's important to them, and how can we work together towards changing that. And lastly, shifting from a one-size-fits-all approach that's decided upon by the clinician only to an individualized, patient-centered approach that assesses all the conditions and factors that influence or are influenced by chronic pain. Next slide, please. Thank you very much.
Thanks, Chris, for that perspective. Are there any clarifying questions? Okay, then we'll go to our last speaker of this session, Jessica Halsey.
Thank you.
Loading up, Jessica, one second.
Appreciate it. So I thought I'd start with just a little bit of background about Addiction Policy Forum for context, very brief. Addiction Policy Forum is a patient advocacy group for patients and families and caregivers experiencing a substance use disorder or in recovery from a substance use disorder. So we cover the full spectrum of types of substance use disorders and have a very diverse membership, from people with an active substance use disorder, again, the family and caregiver voice, as well as individuals in recovery and individuals currently receiving treatment. We also work with stakeholders, whether it's clinicians or policymakers, criminal justice partners, public health, employers, to make sure that they're at the table, as well as researchers and scientists. So we're trying to build the patient advocacy sort of voice and pieces for this space that hasn't typically been around to help patients and families. So that's our goal. We work, the next slide, in all 50 states with volunteers and state chapters that engage. We work very hard to translate the science, where we have amazing clinicians and researchers on this conference today. The vast majority of, or half the public that we work with, don't understand addiction as a health condition. And so bridging that gap between what we know about addiction, what it is, also a chronic health condition, and translating that to the public and to individuals in this space is something that we work very hard to do. Next slide. So I thought today that I would give a lot more about some personal perspectives and want to share with you sort of words and experiences and feedback directly from patients and families to sort of give you a bit of context. So less on sort of the quantitative side, but giving some real qualitative data So you can step into the shoes of individuals, both families and patients that have an opioid use disorder, and again, sort of in that broader context. Now, the one thing I wanted to start off with in sort of the active substance use disorder space is when it comes to our members and the folks that we work with that have an opioid use disorder, there's a smaller cohort that have experienced or have developed an opioid use disorder because of, you know, a lot of the all stops that occurred or improper tapering. And so that physical dependence piece sort of gone wrong and they're here. But the vast majority of even those that we work with that have an opioid use disorder did not begin their use with opioids. Many struggle with alcohol use disorders and have a polysubstance use issue that you know, comes to involve opioids. So to give you a sense of sort of the scale, we have lots of feedback from our membership about polysubstance use as the major issue. And the other piece on the active substance use disorder, and I want to share a couple comments and feedback from our patient community. For those that are actively using, they talk about loss of control very commonly as sort of that personal experience. And one of our individuals describes it as despite your life falling down around you, not being able to control that. The other piece about this that we hear often is having a real understanding of the physical symptoms. And so many of folks in our network just describe trying to stop opioids in particular, which is a combination of your worst flu plus the worst diarrhea and stomach cramps you've ever experienced times 1,000. And all that you have to do is use again to get those symptoms to stop or to be remedied a bit. So just the what they're up against. There's also a lot of experiences of stigma. Was very, grateful for Dr. Earnshaw's overview of stigma, because the real experience of that can sort of delay treatment or delay wanting to engage because of sort of knowing what's coming at you, both from family, from your community, and from healthcare, which can be hard to deal with. When you're called names like junkie and addict and worse, and sort of that feeling of less can exacerbate that internal stigma and that shame and guilt that can keep you sort of in the shadows longer and not engaging healthcare and treatments for yourself. And on the other side, when we talk to our individuals in recovery and those seeking treatment, some of the parts that are really difficult and we hear often is learning new coping skills in a space where you might not have insurance coverage. You're told over and over that this is not life or death. You have to fail first, and sort of feeling that there's one roadblock after another. And then once you're able to find recovery support services or work on long-term recovery, all of the challenges. So imagine, and one of the men that we work with, he has such a great way of putting this in perspective. Imagine if everyone on this call today, that you had to pretty much stop contact with most of your friend group in one day and rebuild from scratch. Imagine if, in addition to that, your family relationships may also be counterproductive to your recovery health and long-term care for your chronic health condition. Rebuilding those social connections while trying to manage all of the intricacies of being in recovery and maintaining that recovery despite stressors that happen in your life can be very difficult and time-consuming. And then for our individuals in receiving treatment, sort of the vast amount of hurdles that our patients have to navigate on a daily basis. One individual, shared having an opioid use disorder, connecting with care, getting coverage, but the expectation by probation that they, because so many of our patient group are justice involved, managing the requirements of finding a job and keeping a job, but you have to show up and wait in line every morning at your methadone clinic, your OTP, and still manage to get therapy and the counseling sessions required, and having IOP in the evening on top of your OTP appointment, while having limited transportation, limited resources, and again, sometimes compromised social structures that help with that. So having to rebuild that from scratch. So what our network is trying to balance on a daily basis can feel pretty overwhelming on any given day. And I think the other piece that I think is really important to note here is that one of the most difficult experiences that both our individuals with an active substance use disorders, those that are in treatment now and even in recovery, is managing the shame and guilt, right? Outside of sort of the stigma that exists and it's coming at you from the community, understanding your own behavior and picking up pieces and figuring out your why you lost control, and dealing with repairing relationships, both family and friends, significant others, your children, and understanding this as a health condition and those change priorities in retrospect is very difficult and can take a long time to build up some of the self-esteem portions and deal with the internalized stigma, that sort of shame and guilt filling that can be very overwhelming and can be a trigger for a slip or a relapse. So ways that we can manage that and help our patients, not just the public, but help our patients understand the sort of, this is a health condition, a chronic condition, and also a little bit what happens sort of when addiction occurs with brain science and reprioritizing priorities of an individual to explain what they're sort of digging out of is incredibly helpful and doesn't always happen as often as it should. And then I wanted to share a little bit on our family member and caregiver experience. The family and caregiver voice is really important, particularly for our network of families who've lost a loved one to an opioid overdose or to an overdose or other sort of loss categories. We have a growing number of families who've lost a loved one who struggled with an SUD to death, suicide death, and then other long-term health consequences of an SUD. And the thing that is really important on the family space is that there's a profound impact on caregivers and families. Sort of adolescent brain disorder, so this is a disease that often begins in adolescence, so you have parents that are very engaged, but also sort of the ripple effects on the family system can be pretty significant. So providing services and care to the caregiver space is also a priority for APF. So on the family space, awareness campaign, when the overdose fatality numbers come out, we relaunch the campaign every year. And so the campaign is 185 a day with 2018 CDC numbers. But the things that we hear from our families and caregivers are a lot about all of the myths and misinformation that exists out there for families. I think one mom explains it as drowning in a sea of worry and misinformation, right? When you Google, and we typically find the families that are in need is usually moms, sometimes starting on Sunday through the wee hours of the morning on Monday, who are texting and calling our helpline and on our website trying to figure out what this is. And so a lot of misinformation is there. When you Google and you start to try to figure this out, there's a lot of bad actors and misinformation that exists. So finding the right source of information. We are much more likely right now to have that mom or dad or an individual, a patient, Googling and looking for rehabs that are, touting expensive services and private chefs and very high thread count sheets, instead of finding a doctor locally and getting an assessment and having a healthcare response. So changing those behaviors and the information that is out there to this is a health condition and to find access to healthcare is something that we work hard at, and there's still a lot more re-education we have to do. We have to sort of uneducate folks. It's sort of, we've talked a little bit about the de-implementation, and I think that's similar here in many ways. Some of the myths and misinformation that we're dealing with are myths of rock bottom. Our families are told to detach with love, and when it gets worse enough, that individual will magically be ready for some type of care and find it on their own. Or they're told to let it run its course. This is what happens with young adults. They're told that 28 days of that fancy treatment place is going to be a cure, like it is a magic portal to curing a chronic illness. When you finish that, there's not a focus on managing a chronic health condition and all of the pieces that need for a biopsychosocial response, or even looking at longer than just that 1 month of a fairly dangerous illness that needs to have a lot more aftercare and reentry planning as they come out of inpatient facilities. The doctor piece is also a big one, is counseling families that this is not a moral failing or a character flaw, and that healthcare should be engaged. It needs to really be broken down and be made more available. And then in terms of our families, I just wanted to share a few stories and sort of real families that have experienced this. So on the top left of your screen, this is Cassidy. Cassidy died of a fentanyl overdose at 22, and her mom says that she was our sunshine, our beautiful angel. And right below Cassidy is Anthony, who loved music and cooking. He would cook for his entire family. And his brother Gino says that the disease of addiction is a merciless, non-discriminatory devil. The loss of my big brother has created a sore on my heart that will never heal. We must fight to end this epidemic. We owe it to every life that has been lost. This is Dylan and Matthew on the top right of your screen. Unfortunately, we have so many more siblings in our network of families who've lost family members, and sort of grief and loss is a trigger for those who are in recovery. It was really what happened with Dylan and Matthew. Dylan was 19 when he passed away, and Matthew 28. And their mom, Denise, writes, which I think is a beautiful summary of sort of how so many families feel. Had they suffered from diabetes or skin cancer, they would have been provided the medical care and attention necessary to live a full life. And this is April with her daughter. And April's mom, Annie, wrote in her letter to us as part of the 185 a day campaign that the hardest thing I've ever done was to tell this 4-year-old girl that her mommy had died. So just a sample of the real experiences of families and how complicated addiction is, and preventable and treatable illness. And every family that we work with want to share their stories so that they can prevent this from happening to other families. Next slide. Another thing I wanted to mention is on Wednesday, Addiction Policy Forum is releasing a research report of survey results. We conducted a very quick survey and turnaround of a project with some funding support from NIDA, because the COVID-19 pandemic is presenting really specific challenges for our community. And so I wanted to go over just a few and not take too much time on a COVID bunny trail, but it is of concern to us. We had 1,079 individuals complete the survey. We have 46 of 50 states represented. We only recruited for the survey for 2 weeks, a little less than that. So our hope for future research projects is to have a larger representative sample. But I wanted to just touch on a couple items before I close up. One is that 1 in 3 individuals reported disruptions or changes in their treatment and recovery support. Those that reported disruptions also had more emotional distress that was reported. So the changes in particular to inpatient treatments or to recovery support, face-to-face 12-step support, which is sort of the backbone of recovery support in our country, has been really difficult on our patient population. The other thing that worries me is we had 3% of respondents report non-fatal overdoses and 1% report fatal overdoses. We also had one death by suicide death reported, as well as many sort of writing in suicidal ideation and some several failed suicide attempts. So it's concerning sort of what the impact is going to be when this is conflated together. The next slide. The other piece that came out is that treatment is changing, that we had 54% are receiving that have changes in their treatment or recovery support are reporting that they're receiving telehealth services. They're able to pick up curbside or get deliveries of medication or have take-home doses. But there's still sort of distress over the virtual options and the telehealth options not adequately meeting the needs of individuals that are seeking help. And then there was also some reports of finding difficulty accessing naloxone, as well as syringe service programs, as well as those inpatient treatment programs. Next slide. Overall, we had 1 positive COVID-19 test, but we had 9% of respondents who have experienced symptoms but were not tested. Lots of questions in there for future research about is that insurance access, is that fear of infection and not wanting to engage in healthcare, or is there any impact of sort of feeling sort of judgment or stigma from healthcare that sort of dissuades individuals from engaging. A lot of questions there. And then we also sort of learned that the top emotions were worry, sadness, and fear. Social isolation was up there among the concerns. And while becoming infected and hospitalization are high on sort of the top concerns, that social isolation piece ranked very high as well. Again, for those interested, this is a early peek. This isn't actually released to the public yet. That comes on Wednesday. But I do think it signals to us that more research is needed and also more wraparound support and services for our entire patient group, and not just patients, but also families who are expressing sort of feeling triggered, their grief is triggered, the isolation and social distancing is affecting access to grief and counseling support as well. So really being ready to address the needs of this population as we start a phased approach to come out of it. And also to pay attention to the increase in, is this an increase in reported overdoses? What is this going to do to the progress that we've made on our opioid overdose numbers and experiences? Many of our folks that we're working with, even for individuals who have long periods in recovery, are shocked and expressing their own sense of surprise at how difficult this has been for them, and that the protection of years in recovery doesn't seem to have as much effect as they had intended or had expected. Why is this so difficult in the shutdown? Why is this so difficult to maintain my recovery? I'm 20 years in, I'm 15 years in recovery, and the lack of having access to my groups, my 12-step, combined with the stressors of this pandemic, is putting me in a place that I never anticipated I would be. So I think it you know, I think requires us to pay attention and to being able to engage not just patients in treatment, but those in recovery and even in long-term recovery, to make sure that they have the care that they need throughout this year. Next slide. Just very quickly, some of the things that we work really hard on are the stigma piece. It has such a profound effect on how we access care and stay hidden in shadows instead of seeking help for ourselves, our children, our family members early rather than later, and improving that treatment and helping patients and families in crisis, helping them find you and clinicians instead of the first 40 pages of silliness on Google is so critical to us change. You know that if you your kid has a really bad cough, you've got a terrible rash, you think that they you know, have something that needs to see the family physician, to see the pediatrician, for your spouse or significant other to go seek care for you yourself. And we're not quite there yet as our patient group to understand how they can recognize symptoms and engage in care earlier. But it's something that we can achieve, I think, working with key stakeholders, as well as engaging and educating our patients and families themselves. An educated marketplace, having sort of the patients and families themselves have access to the most up-to-date information as possible, can have profound effects on how the outcomes for our patients and how quickly we intervene with evidence-based interventions. Next slide.
Jessica?
Yep.
Yeah, and oh, you're at the end. Okay, great.
Thank you.
I just, yeah, and one thing I wanted to thank Jessica for, and just it's a good reminder for the group. Obviously, COVID has made some really dramatic changes to the kind of care people are getting. And, you know, to think about how some of those things, I mean, obviously there's a lot we don't know, but what are some of the implications for things that are likely to be more sustained ways of delivering care in telehealth? And I'm sure we'll get a chance to weave that in. So thanks for a really good presentation. Any clarifying questions for Jessica?
So there was a quick question just in terms of the number of respondents in the survey, Jessica, and then we should open it up for the full discussion.
There's 1,079 respondents.
Thanks. Okay, thank you all for a wonderful set of presentations. Lynn, we had a couple questions that came in during the presentation. One, the first one for Dr. Williams from Wilson Compton. He's the Deputy Director at NIDA. And he's talking about distinguishing addiction from withdrawal or pain-mediated drug seeking has been difficult. And Dr. Debbie Hassan has been doing some very interesting work on this topic and may have some ideas for how to maximize the separation of the phenomena of opioid use disorder from pain and withdrawal related drug seeking. So I don't know whether you have any comment here.
Or Wilson, if you had any additional clarification or things you wanted to add for the group about your comment. Okay. I also noticed there was a comment that Bob Kearns made at the second presentation, really about the public perception of malingering and exaggerating secondary gain for pain, and how do we address those kinds of things and sort of square it with what we know about the biopsychosocial model. Bob, do you want to say a few more words about that?
Yeah, I think, you know, it's really, you know, the person in the email was, I think, getting at malingering and secondary gain, but really it's the real pain, not real pain question, right? The public, I think, and too many providers still are caught up in that kind of thinking. And we can all agree that we don't think that's the way we should be talking about pain or understanding pain, going into a clinical patient-provider interaction with that question in mind at all. But it's continues to be a challenge, and I've been disappointed that our government hasn't invested in a large public health campaign as other countries have. But short of that, what can this research community and the NIH, in particular, maybe in the context of the NIH HEAL Initiative, be doing to, really make a dent, at least, in that public health, public perception?
So this is John Farrer. If I could respond in some way, it is almost impossible to know how to validate patient complaints of almost anything. But one of the perspectives that has been useful, or at least over my career, has been the issue of deciding whether the medications I'm giving the patient are allowing them to live better lives, or are the patients living their lives to get the medication? And while that sounds sort of simplistic in some ways, it may get at some of the issues, and I'd be interested in Bob and others' response to the concept that if a patient is taking a set of medicines, whether it's for their diabetes or whether it's for their blood pressure or whether it's for their pain, what we're really interested in is improving their lives and helping them function. And the degree to which we can demonstrate that through a variety of measures, it seems to me, might be a way to understand whether what we're doing is beneficial, and gets us away from the need to sort of differentiate what it is that we're actually treating, and whether whether it's the specifics of the pain or whether it's the response of the patient to the pain, whether we're using an opioid, whether we're using an antidepressant, whether we're using a physical therapy. All those tools really ought to be accentuating patients' lives. And Bob, I don't know if you've thought about that.
This is Chris. I certainly agree with you, and it's something on the HEAL multidisciplinary work group that members have discussed, and not to put the HEAL leadership on the hook here, but have brought to them in terms of something that really needs to be done, and stigmatization and like-minded research. And something that John said earlier, and I'm paraphrasing here, but basically said that now that we have MRI findings, it's not up for debate anymore as to whether pain is real or not real, right? And the point that I want to make by that, and something that we've communicated to the HEAL leadership, is that getting the science out to the public helps to legitimize and destigmatize these conditions. And that it's really, really important that we as a community, not just the NIH, but all of us, work to really do everything that we can to put rigorous research findings out to the public to help them understand what pain is. I mean, I certainly agree with you that we do need public education campaigns, but promoting the science and getting it out there really helps to destigmatize and legitimize the conditions, not just pain, but addiction as well.
One of the problems, though, is is the huge complexity in the way these issues intersect. And this conversation really reminds me of something that Jane Ballantyne said at the 2014 NIH workshop. I think that probably was in some ways the predecessor to this one. She said that from the perspective of the brain, when you're trying to assess the efficacy of an opioid, and you ask the patient, did this opioid alleviate, did it bring relief? The patient's brain can't discriminate whether the relief stems from relief of physical pain relief of emotional pain, and relief of craving from withdrawal, which at least in terms of short-acting opioids occurs on a near daily basis. It's all conflated in the brain. And so therefore, from that perspective, it does make it difficult to give a clear message.
So I wanted to say how well, Eric, your point really illustrates the, of the purpose of us coming together is how these things intersect, and the science along with the patient voice really being very central. I want to note we're into our 30-minute break. I think taking maybe another couple of minutes if people had some comments. This is the most packed session this morning, and I think laid an excellent foundation, but we'll have a lot more chance for discussion in upcoming sessions and to really unpack this. So anything else that people wanted to add to this discussion before we break for about 15 minutes before the afternoon presentations and discussion?
This is Rebecca. I just wanted to acknowledge Chris's comment and point of emphasis that stigma is something that we've been working within the initiative to incorporate into ongoing HEAL research studies through a set of notices for administrative supplements. But I also think the questions of how we talk about it, how we share our research findings, how we continue to use the initiative as a vehicle for sharing our perspective, which isn't necessarily the same one as the research community and the medical community at large, is something that the HEAL Initiative and myself were interested in continuing to discuss and explore.
Great.
I'll make a comment. This is Bob. I think I also particularly impressed with Kristen, her longtime advocacy and her presentation this morning. And to Eric's point, I think two things that I'm happy that the VA Health Services Research and Development Service has been emphasizing in investigator-initiated awards is integrating the voice of, in that case, the veteran, more broadly for the NIH, the voice of persons with pain and/or opioid use disorder, into the identification of key questions, design of the problem, really all the way through the process, kind of a PCORI model, and also the importance of, when appropriate, but I think for pretty much any research that we're doing other than preclinical research, paying attention to integration of implementation science methods with an eye to doing something with our findings and products beyond publishing in peer-reviewed journals is very important.
This is Stefan, and I wanted to comment on this issue of patient voice and actually delivering care. The question of relief, which Eric raised, the patient will always say, this thing is relieving me. But what we want to know as clinicians in the process of care delivery is how is any treatment intersecting with the advancement of a set of goals to which your life is moving toward. And the only way those goals can be disclosed is by setting up clinical environments in which the staff are both prepared, ready, interested, engaged, respectful, non-judgmental, and wholly in a frank conversation about, well, I noticed that you were on the job yesterday at the hospital and it looked like you were having a great time. Or when you talked to me last week about, there's conversations that only happen if clinic managers make decisions about how clinics are going to be run. So there's an implementation question that relates to what happens between patients and clinicians. We study this in the VA's homeless patient-aligned care teams, that you can see differences in how clinics are set up to operate, who they're accountable for, what resources they put in place, and which staff are speaking with patients and having time to speak with them. And then that sets the predicate for whether there's a candid, respectful, non-judgmental relationship in which relief's meaning can be decoded. But that's an operational decision as much as it is a soft and fuzzy human thing. It has to do with how you set up clinics.
Thanks. So I think this was a great discussion, and as Lynn said, we will have much more time for discussion in the other session. So apologies for cutting this one short. I do want to give people some time to take a break, and I know it is shorter now, but we'll start back at 12:30 with session 2. Okay.